In today's episode, I talked to Dawn McDonald. Now, Dawn is a consultant mammographer, and she started her career as a radiographer and decided to specialize in the area of breast imaging. It was an absolutely fascinating conversation, and if you have ever wondered what happens when you go to have a mammogram, for example, what it involves, whether it's uncomfortable, then this is definitely a conversation you want to listen to, because Dawn explains everything related to things that you might need to have if you come to a breast clinic or if you have a breast screening mammogram. And I would also advise you to listen right to the end, because Dawn has given us some really useful website addresses that you can visit if you want to learn more about all things related to breast imaging. So, without further ado, here is my conversation with Dawn McDonald. Hi, Dawn. Thank you so much for coming onto the podcast. How are you?
I'm really good, thank you. And thank you very much for inviting me onto the podcast.
It's an absolute pleasure. And, I've been thinking about asking you to come on for a while now. So you and I have actually worked together on and off for a number of years now, haven't we?
We have. We worked in Essex and we worked in London together. So we've known each other for quite a while.
That's right. And I thought, who would be best for me to ask to come onto the podcast to talk about all things related to imaging in breast? And I thought of you. So you work as a consultant radiographer. For those who don't know what that is, do you mind just explaining to us what that actually means?
Yes, certainly. So let's start off at the basics. So a radiographer is a person that you'll see in all of the hospitals who works in A&D and takes the x-rays. So you could have a broken leg and you'll go to the radiography department, you'll have an x-ray. From there, we kind of specialize in different areas. So people who do CT, who do MRI, who do nuclear medicine, they're all radiographers. And it just so happens that I have decided to specialize in breast radiology. So I do everything to do with the breast. I'm a radiographer. I'm actually a consultant mammographer. I am accredited as this. So
Right.
I do things like I report on mammograms, I do breast biopsies, I do clinical breast examinations, I report on films. So that is what my main job is.
You are a consultant mammographer, and I guess the difference is between that and a radiologist is that a radiologist would have had to go to medical school. So they would have gone through medical school training and then into radiology training, and then they would choose their different specialties depending on their preference. So they can go into musculoskeletal, for example, GI or neuro. Whereas I guess you went through your training through the radiographer route. Would that be correct?
That's quite correct. So yes, I'm not a doctor, and so I haven't been to medical school. But similarly, I've been through my own radiography school where I did my training, and then I specialised in radiography, breast mammography. Some people specialize in CT or MR or ultrasonography. So it's similar to the radiologist specializing, for example, in radiology or pediatrics. So it's two different pathways, just that I'm not a doctor.
Okay. So you've niched really quite specifically down into the breast area, really.
Yes.
As we know, one of the important ways of diagnosing a breast condition is by having some sort of imaging. So that could either be a mammogram or an ultrasound scan, or sometimes we have to do an MRI scan. Can you tell us exactly what a mammogram is? Because obviously we hear about mammograms a lot, and many women would have had a mammogram. But, can you just explain to us what that is, please?
Yeah, so very, very basically, a mammogram is just an X-ray picture of the breast. So, and we do that so we can see the internal structure of the breast to see if there's anything brewing in the breast, and we can look down at the breast tissues. So very, very basically, it's just a snapshot picture of the internal side of the breast.
And if, say, somebody were to have a mammogram, they would go into a room with the mammogram machines are actually quite large, aren't they? And they do look a little bit intimidating. What actually happens when you have a mammogram?
Right. So The lady will be greeted by a very, very able radiographer they are excellent in their job. And
Right.
one of the first things that they're very good at is putting the patient or the client at their ease, and they will talk to the client what they're going to do. So basically, it means the lady has to strip down just to the waist. So everything from the top comes off. And then she'll be placed into the machine, and the radiographer, the mammographer, will bring the plate down onto the breast, checking all the time that the lady is very comfortable, and they will be talking to her all of the time so they know what to expect. So the plate comes down quite tightly, and the radiographer then, people see the radiographer running around the screen, but that is
Right.
just take the image, because all the functioning the functions of the machine are behind the screen. They take the image, and then as soon as the image is taken, the plate is released. So the compression only lasts a matter of seconds on the lady. A little bit uncomfortable, but it's very, very quick.
Right. Okay. And you have to take two different views. Is that right?
That's right. So on each breast, you will take two pictures. One is it's a CC, where if you can imagine the lady standing in front, just standing upright, and the plate comes down from top to bottom, and that is called a CC view. And then the other one, which you probably see quite regularly on the TV, is when the lady leans into the machine, and the machine is angled at about 45 degrees, and that takes a a sideways image of the breast. So
Right.
between those two views, the CC and the oblique, you should be able to see the whole picture of the breast.
So that gives us a two-dimensional view of the breast, doesn't it?
It does, but by doing the two views, we're trying to replicate a three-dimensional view of the breast by doing two-dimensional imaging.
So then that will generate kind of an X-ray or a mammogram picture of the breast. And then you'll be able to read that, on your really fancy screen normally. There are lots of things that you can look at and decipher from a mammogram. So when you look at a mammogram, what are the things that you look out for?
Okay, so when we do the mammogram, we'll look at both mammograms at the same time, both breasts at the same time, the right and the left breast. And one of the things that we kind of looking at immediately is symmetry. So both breasts should kind of look the same. Now, sometimes if there's an obvious pathology there, you will see that. You will immediately see, well, that breast looks completely different from the other side, and your eye will be drawn to that. So we're looking at symmetry, and then we're looking at things in the breast. You might see a round circle in the breast, which is a lesion in the breast. You might see something in the breast which is called calcifications. It looks like specks of salt in the breast, and these are chalk. So you're looking like things like that. You might also see that the breast might be pulled in as well. So you're looking for a kind of distortion in the breast.
Right.
Sounds very easy, but it takes a lot of your eye takes a long time to get used to this kind of looking in the breast. It's basically you're looking at picture recognition of the breast to find out what doesn't look quite right. So yeah, calcifications, a mass in the breast, things like that, distortion.
Right. So, yes, forgot to say that when you have a mammogram, both of your breasts are actually done, aren't they? It's not just the left or the right. So you get both of your breasts mammogrammed, and then you compare your left to your right. And then, as you said, you compare the two pictures side by side, both the CC view and the oblique view. And
That's
then you
right.
can compare and contrast.
That's right. That's right. And it's easy to do it that way because as we are aging, the breast should kind of change at the same time. So as we're getting older, the density of the breast, the tissues of the breast should change roughly about the same time. So it's easier then if you have the both breasts to compare.
Right. Okay. Some women say, "Oh, I've got dense breasts." What does that mean in terms of what you can see on the mammogram?
Yeah, so this is the difficult and the difficult one. So dense breast, the younger you are, the denser your breasts are. So in terms of mammography, the breast tissue, when you look at the mammogram, I'll just say that it looks white on the mammogram. So if you just got like a sky or a picture of just whiteness, it's very difficult to distinguish the actual workings of the breast. So Mammogram is very, very difficult for ladies who have dense breasts, and this is why we don't do mammograms on the younger ladies. So the younger you are, the more difficult it is to decipher through the breast. So under the age of 40, we won't use mammogram
Right. Okay.
unless there's a real clinical need to do that.
Right. Okay. So usually, and you can correct me if I'm wrong, if somebody's breast is quite dense, the mammogram looks, slightly more white, doesn't it? Whereas
It
if
does.
somebody has a less dense breast, and the fatty component is more predominant, then it's kind of more dark.
That's completely correct. And it's easier to visualize through the breast the darker that it is as opposed to the whiter that it is.
Right. Okay. So that is one of the reasons why we don't do mammograms in women under the age of 40. And I think that's kind of an important explanation, because many would say, oh, I was told by somebody that I need to have a mammogram, and you're 28 or something like that. And the reason why we don't do mammograms in younger women is because of this denseness of the breast.
That's quite correct.
So when somebody has a mammogram, and you find an abnormality, for example, then what happens normally?
Yeah. So one of the things I like about my job in terms of finding an abnormality is that I work as part of a team. So quite often the surgeon, somebody like yourself, will have done a breast examination and will have said, yes, there's I can feel something in your upper outer quadrant of the breast. So then when I look at the mammogram, I'm not automatically, but I will be looking at where the likely area of concern is going to be. I'll do the mammogram, report the mammogram. If I then see something that I think needs further investigation, I may ask for further specialized views with the mammographer. So the lady might be taken away and further films are taken. Or I might decide that I just need to do an ultrasound of the area that I can see.
As you rightly said, normally, because we normally work in the symptomatic clinic, where somebody would come into the clinic and, they might come with, say, a breast abnormality, like a lump, for example. People in the UK, when they come to the clinic, it's called a rapid assessment clinic or a one-stop breast clinic, where if it was our clinic, I would have examined the patient and I find a lump, for example, then you would have already had done the mammogram. You would have looked at the mammogram and you might say, okay, yes, I can see what you can feel. Then you would do an ultrasound scan specifically looking at the area of concern. What is the difference between an ultrasound scan and a mammogram?
So the main difference is that a mammogram uses X-rays to find any pathology in the breast. An ultrasound does not use X-rays. An ultrasound uses sound waves to hone in on the area that's been shown on the mammogram. And one of the strongest things about an ultrasound is that it is very useful in distinguishing between lesions which are cystic and lesions which are solid. Now, on a mammogram, you might see a lesion on the mammogram, or you might see an area on the mammogram and you think that needs investigation, but I can't tell from the mammogram whether it's solid or cystic. By
Right.
using the ultrasound, I will immediately be able to tell if it is solid or cystic, and that is one of the strengths of the ultrasound. It's very, very good for differentiation.
Right. Okay. So you can see something on on the mammogram. It looks not quite right. It could be solid or cystic. So you do the ultrasound scan, and an ultrasound scan is, I guess, something that if if you've been pregnant, it's the exact same machine that you would have had used to examine your pregnancy. That's right, isn't it?
That is right. It's just the frequencies are different.
Oh, okay. So now you found something in the on the mammogram. You've scanned it on an ultrasound scan, and you might say, okay, this is actually a benign thing. So a cyst, for example, which are non-cancerous, very common conditions in the breast. What happens then if you find it is not a cyst and needs a biopsy?
Okay, so if it's a cyst, that's great. Most women, that is what we see mainly is a cyst, and we can reassure the lady or drain it. If it's not a cyst and it does need a biopsy, well, we can do that under the ultrasound in the room at the time. And it's not a very very dangerous. It's not dangerous at all, or it's not very traumatic. But basically, what I would do then is put some local anesthetic into the breast at the area, and I would just take a tiny, tiny sample of that lesion, and then that goes off to pathology to get tested under the microscope by our very clever pathologists, and they will then give us the diagnosis of what that is.
So that would be good if you can see what you can see on the mammogram on the ultrasound scan. Now, what happens if you saw something on the mammogram and you scan that part of the breast and you can't see that thing on the ultrasound scan, which can happen sometimes, can't it?
It can happen, and it does happen, quite fairly significant amount of time. In this case, we can do something called an X-ray guided biopsy. And the type of presentation that this usually is something called calcifications. Now, calcifications are basically it's chalk in the breast, and we see this quite a lot. And unless the calcifications is obviously benign, it is almost impossible to distinguish whether it is benign or malignant, which means that if we see calcifications, we are very, very likely to do an X-ray guided biopsy of the calcifications.
So you have to do it under X-ray guidance because you can't see it on ultrasound scan.
Sometimes you can see it under ultrasound. If there is a lot of calcifications, you can sometimes see it, but most of the time you can't, because the calcifications, a lot of the time, there'll only be a very, very tiny amount of the calcifications. It might just be an area of about 4 or 5 millimeters, and you
Right.
can't really see that. So then it's just easier and safer to do it under the X-ray, and you're more likely to get it first time under the X-ray as opposed to the ultrasound anyway.
How can you tell what kind of a benign microcalcification looks like compared to a malignant or slightly more suspicious microcalcification on the mammogram? What are the different characteristics?
Yeah. So benign calcifications is usually larger in size, called macrocalcifications, and sometimes you see something called popcorn calcification. So if you can imagine what popcorn looks like, big popcorn, we see that, and that is usually a benign sign.
Right.
Now, malignant calcifications, usually it just doesn't look nice. It's all different shapes, all different sizes, all different densities. Sometimes it's pointy. It just looks very, very malignant. And when you look at it, you will say, yeah, that just doesn't look nice. I mean, that is obviously a sign of malignancy. However, as I said, quite often it's very, very difficult to distinguish between benign and malignancy. And this is one of the reasons why we end up doing lots of biopsies on calcifications, which then results in giving us a benign result. Because you see something, you think that is definitely going to be malignant. We do a biopsy and it turns out to be benign, and vice versa as well. So calcifications is probably the bane of the radiology, the radiology world. Really, it is.
Is it?
Yeah.
There have been times when we're kind of always, well, not you, I guess, you rather than we, because I don't do it, you do it, but you kind of always have to chase the microcalcification because sometimes you sample it and there's no calcium in the specimen, so you have to chase it again. So yeah, I guess because it's such a small area, and if you think it's a small area in a sea of breast tissue, it must sometimes be quite hard.
Yes, it is, and especially for ladies who are quite generously, quite generous breast size, it's
Yeah.
very, very, very difficult. And sometimes it can be like looking for a needle in a haystack, because the calcifications, it can be so, so tiny, but we want to find it because we just know that the earlier that we can find these calcifications, the better the outcome for the ladies. So we will chase and chase and chase until we are happy that we have a proper and definitive result.
So what is calcification? I mean, why do we get calcification in the breast?
Chalk. It's what calcification in the breast basically is just chalk in the breast. And I know you get chalk all over the body, but it's essentially just chalk in the breast.
Right. Okay. And it's nothing to do with, people kind of having more calcium or drinking
No,
more? Yeah.
it isn't. It's not that. And it's funny you say that because sometimes we'll say, we can see these calcifications, we can see that it's chalk, and they'll say, oh, is that because I've been drinking lots of milk? And we'll
Yeah.
say, no, it's nothing at all to do with that. It's just
Yeah.
the way the body is.
Right. Okay. Sometimes the other way around happens. So sometimes we can feel something in the breast. We can see it on ultrasound scan, but we can't see it on mammogram.
That
We can see kind of worrying signs, clinically worrying signs on ultrasound scan. But when they had the mammogram, there was nothing to be seen on that. Can you just explain a little bit about that?
Yeah, so mammograms is not 100%, and we do have some cancers which are occult, basically. So basically, these are breast disease, breast cancer, which are not at all visible on the mammogram. They are occult cancers. However, you go onto the ultrasound and you can clearly see it. And these are always a surprise because the lady will have come in and she says, I can feel something on the outer half of the breast. She has a mammogram. We can't see anything. And then we put the probe on to do the ultrasound, and there is something, what she can feel, what we can all feel, but we cannot see it at all in a mammogram. And they are a surprise to see
Yeah.
those type of pathology.
Yeah, and we've had a few of those, haven't we?
We have. We've even had some cancers that have come through. You can't see it on a mammogram. You can't see it on the ultrasound. We can feel it. And then the next
Yes.
step then is MRI. And then you can see it on the MRI. But again, they are very, very few and far between.
Yes, that's right. So if you have, as you said, an occult cancer on a mammogram, then the next thing would be to have an MRI scan. So an MRI scan, is a completely different modality, and it's used to look at lesions that are mammographically occult.
That's right. That's completely correct.
So if we move to a different area, which is screening, because you and I work in the symptomatic clinic, but you are also involved in the screening program. And, in the UK, we have a breast screening program that is, nationwide, and women are invited to have a mammogram every 3 years. Can you tell us a little bit about the screening program?
Yeah, I can do that. So screening is, the aim of screening is to detect cancers, very small cancers in a population of women who have no symptoms. And generally, screening starts around about the age of 50-ish, some part of the country around about 47. And what happens there is that ladies will be invited around about the 50th birthday every 3 years to have a mammogram. And from these mammograms, we will pick up very, very small cancers, which is what the aim of screening is all about. So the lady will have this screening. If she is diagnosed with a cancer through the film reading, she will then come back to the unit for further assessment.
When somebody has had a screening mammogram, they're normally notified, if it's all fine, then they will get a letter to say it's all fine. If we have found something abnormal in their mammogram, then they get what's called a recall. So then they will come to our hospital, or, different kind of units around the country to get an assessment. So if somebody, for somebody who has been recalled from their screening, what can they expect to happen when they get recalled?
Okay, so the first thing I would say is they are not to worry. Do not panic about this at all, because most women who come back for screening, everything it's benign. By the time we've done the assessment, it's benign and we don't find anything. However, what happens when they come back to the unit is that we look at the films and we will show the lady what we can see and the reason why we've called her back. There might be something on the mammogram in the left breast. She will then have further imaging by our mammographers, and quite often this further imaging will be enough for us to say, yep, there's nothing on the mammogram, it was just an artifact at this stage, so we don't need to go any further. However, if it's not an artifact and it really is something that needs to be dealt with, she will have a clinical breast examination by myself or my other radiology colleagues, and she may or she may not have a biopsy of what we can see. So that's what happens there. So breast examination following with an explanation and a biopsy, which may be done by ultrasound or it may be done by X-ray.
So further views is, so basically if somebody comes to the unit because they have been recalled, normally what happens is there is something not quite normal on the mammogram. And as you said, it could be what's called an artifact. So these further views would be where the breast is compressed in different ways. And if that abnormality goes away, that means that that abnormality is nothing to worry about. Whereas if it doesn't go away, that means that abnormality is probably real, which would then require a biopsy. Is that what happens?
That's quite correct. That is 100% correct. So if it disappears, it might have been a movement, and the lady may have moved when she had her initial mammogram on the van. So the further views will let us know that that is what it is. But if it doesn't go away, it probably is real. I have to say as well that we are looking at very, very small things as well, because usually, because of the screening program, the lady will be getting recalled for something that she will not feel, and we probably won't feel it either, because we'll have picked up something sometimes years before she will even be aware of, there's anything wrong with the breast. And this is the beauty about the screening program. We pick up these very, very small things very, very early if they are real.
Right. Okay. And then obviously if it doesn't go away, so if this abnormality is real, then it would be biopsied. If they can't see it, if you can't see it on an ultrasound scan, to biopsy, because obviously I'm assuming that's a preferable way of doing a biopsy, then they'll have a stereo core biopsy or a biopsy that's done under mammographic guidance.
Yes, that's quite correct. Mainly it's done under ultrasound, but sometimes you do have to do it under X-ray. Again, if it's calcifications, as I spoke about before, it will be done under X-ray.
Right. As you said before, the screening program is between the ages of 50 normally and 70. It's been extended, had been extended to start at the age of 47, depending on where you live. And anybody beyond 70, well, actually, it was extended to 73, I believe. Beyond that age, if you want to continue to have a screening mammogram, then you have to self-refer.
That's right, and I would always encourage anybody over the age of 70 or 73 always to continue having screening, because the thing about cancer is that it's an aging disease. So the older you are, the more likely you are to develop a small cancer in the breast. So I would strongly recommend that even when the screening age stops, to please continue to come in to see us.
Yeah, no, absolutely right. Obviously, we are in the midst of a pandemic, but of course, hopefully the end is upon us with the vaccine just around the corner. Well, obviously, the breast services have been impacted, and not only the symptomatic service, but also the screening service. And the screening service was postponed and I guess suspended for a number of months.
Yes, it was suspended for a number of months, and I think some hospitals still haven't started yet, I think. But we have started again now, and we are slowly trying to pick up all the numbers that we have left behind. More difficult nowadays because of all of the cleaning that we have to do and the COVID restrictions. It means patients are coming, or clients are coming through to see us less frequently. Maybe on the vans before, on the screening mammograms, they would do about 50 patients a day. That may be down to about 20 because of the time intervals we have to leave in between patients. But yes, we have started to screen ladies again, albeit slowly.
For those women who are due a screening mammogram, they'll probably get it, but it will be some months down the line rather than it'd be later rather than sooner.
Yes, that's right. It will be that.
Yeah, and I guess that puts the importance really on being breast aware and making sure that everybody examine their breast regularly.
Yeah, that's right. So it's even more important now. if you do have any issues at all with the breast, to please just come and see us or your local breast screening unit. Very, very important that you do this, because if you are relying on a screening to come through, it might be a long, long time before that does come through, whereas we can help you more readily in the symptomatic services. So yes, I would encourage anybody who has any issues or any concerns to come and see us.
Yeah, no, absolutely. I think, many women who I have seen would say, I just don't really want to have a mammogram, or I'm slightly afraid to have it, or I'm rather anxious about having it because I hear it's quite painful and it's uncomfortable. Would you be able to appease and allay people's fears about this?
Yeah, it's not. I think people have got this idea in their heads that mammograms are really, really painful, and it's not. I would say maybe a little bit uncomfortable. The majority of women don't even feel anything at all. The breast gets squashed tightly, but it's for a matter of seconds. 5 seconds maximum. So it's not as painful as what you think it is, and a lot of people will say, I didn't even feel anything anyway,
Yeah.
So I would just say, you have to, you come and judge for yourself, but it's not as bad as what you think it is. And the mammographers are very, very skillful. They're very, very good at their jobs, and they will do what they can to make it as comfortable for you.
Yeah, no, absolutely. Everybody, they're very, very sympathetic because, they know that women can be quite anxious about having a mammogram, especially if you have never had one before. But definitely it's not painful. It may be a little bit uncomfortable. The majority of the time, women tolerate it very, very well. And, they come out quite surprised to say, oh, actually, that wasn't that bad at all.
That's right. I find that all the time. They are surprised themselves that it wasn't as comfortable as what they thought it was going to be. So yeah, that's
Yeah.
quite right. Yes.
Yeah. I mean, I guess the thought of having your breast squashed is not, it's not something that, makes you jump with joy, but it's actually not that bad at all, is it?
It's not that bad. And people are wondering why the breasts are being squashed. And the reason why we squash the breast is that we want the breast to be as thin as possible, because the thinner the breast is, the clearer the picture we get of the breast. So we can see a lot more clearly through the breast. And that's why we squash the breast as much as you can tolerate it.
I just remembered, a common question that I get asked also is with implants. Many women have implants and they feel that, I have implants, it's going to be really uncomfortable and I can't have mammograms. That's not true, is it?
That isn't true at all. And again, the mammographers are very skillful in dealing with ladies with implants. I have been doing this job for hundreds of years, and I've never known there to be any implant injury at all, or any harm come to the implant. So yes, I would please, even if you have implants, please come for your mammogram. Don't let that put you off. The girls
Yeah.
are very, very good. They're really good.
Yeah, no, definitely. Well, Dawn, thank you so much for coming onto the podcast and explaining to us very, very well all the differences and what we look out for and what you need to do when you do your mammograms and your ultrasound scans and all your screening work and looking for needles in haystacks in breasts. I mean, honestly, when I see you read mammograms, I think, what? That doesn't look like an abnormality at all. That looks quite normal to me. But you say, no, I'm a little bit worried about this
Yeah,
tiny area in the breast.
yeah.
So yeah, I think really amazing to watch what you read, what you do and how you read these mammograms, because it's an absolute skill.
It is a lot of skill, and it's a lot of responsibility as well. I will say that, because you want to make sure that you're doing it right for everybody and you're doing the best that you can. So the responsibility is very, very high, and the experience is there as well. But can I just say as well, people go onto the internet because they have breast symptoms, and they Google the symptoms, and they come to see us because they've seen this website that says they have this and they have the other. But there are recommended websites that I would give to people, which I would refer you to get the proper answers if you would like to know what they are.
Oh yes, please. That would be
Yeah,
excellent.
yeah. So one of them is www.isbreastscreening.gov. That's for everything you want to know about the breast screening services. I would recommend that you go to the www.nhs.uk site, very good as well, and also www.cancer.gov. All of those sites are very good and will give you the truth and what you really need to do, the proper indications and what you should or not be worried about, as opposed to going to a website that has been put up by, I don't know, Joe Blogs down the lane or something. So yeah, they will give you the truthful information.
Great. Well, I'll definitely leave those links in the show notes, and so people can check them out if they want to. And that's definitely really useful because there's a lot of noise out there, and to have those signposted is amazing. Finally, do you have any advice for women before we go?
Yeah, I would just say, please, and I've said it before, if you do have any breast cancer concerns, please come and see us. The majority of the things that we see, we can dismiss it. Maybe 9 out of 10, there won't be anything seriously wrong with you at all, and we can make your worry less. We can do the worrying for you, do all of the tests, and you will be fine. We can then discharge you. For the small minority of women who do have a problem, we'd rather see you sooner rather than later, because if there is a problem, it's not going to go away until we sort it out. So please just come and see us. We'll either reassure you and discharge you, or we can start anything that needs to be done very, very soon.
Well, thank you so much. That's fantastic advice. And thank you so much once again, Dawn, for your expertise. And see you soon.
And thank you for inviting me. It's been an honor and a privilege, Tash. Thank you very much.
Thank you, Dawn. Take care.
You too. Bye-bye.
Bye. What a great conversation. Thank you so much, Dawn, once again for your expertise. And I will link all those website addresses that Dawn mentioned in the show notes at www.mybreastmyhealth.com/episode 23. And there you can find the show notes and also those important web addresses. We are fast approaching the end of 2020, and what a year it has been. If you haven't done so yet, do hit that subscribe button, and by doing so, all the new episodes that will be coming out in the future will be automatically downloaded to wherever you listen to your podcast. If you have a few minutes to spare, it would mean a lot to me if you could leave a rating and review on Apple Podcasts. And by doing so, hopefully it will make the show more discoverable to more people who may also then benefit from it.